Hello, good afternoon, everyone. Thank you so much for coming. My name is Boris Bernhard. I work in Montreal at the MNI, and I'm very happy to co-chair this session with Professor Zara Larivière from University of Sherbrooke and Professor Jonathan Lau from University of Western Ontario. So it's a Canadian-led symposium. And today we want to talk a little bit more about the translational impact of the type of work that we are doing. And the name of the session is From Connectome Mapping to Surgical Interventions. So I think you're all in for a treat. So just to give you like this one slide of background, at OHBM, it's a community where we have a lot of advanced methods to study brain networks, both functionally, structurally. We can use it with electrophysiological techniques, with imaging. We can reconstruct fiber tracts. And then obviously the challenge is how do we translate this into the operating room, where sometimes we need to do a focal resection or where we want to modulate specific circuits. So we have a great lineup of speakers. Aileen McGonigal, she's going to do the first talk, and she's a professor here in Brisbane, but also the director of the clinical epilepsy unit. And she recently moved from Europe to come here, so it's very courageous. And you're going to hear her talk about mapping brain networks for epilepsy surgery, a multi-modal approach using stereo-EEG. So please join me in welcoming our first speaker.
Thank you very much, Boris. Thank you, Sarah. Thank you, John, for the kind invitation. I'm really delighted to be here. Thanks for everyone for coming. So I'll just make a start, so no disclosures. So I thought I would just start. I've got just two kind of introductory slides to set the scene and kind of bring some of the thinking around connectomics and networks and all of the exciting things we've heard about in the conference so far into the clinical reality, which is often very complex and quite difficult to apply some of the theories into a patient in front of us. And the patient I'm going to show you is a particularly complex one, so hopefully that illustrates some of the difficulties of what we're facing. So first, some just definitions. So epilepsy is a very important condition to be aware of, and it's a very important one to apply thinking on networks to. It's the commonest severe chronic neurological condition, and it's characterized by this tendency to have recurrent seizures, spontaneous seizures. Any of us can have a seizure that could be triggered by an infection or an injury or something. But people with epilepsy have recurrent spontaneous seizures. And this is our definition. The official definition of a seizure is a transient occurrence of symptoms and signs, so some kind of disturbance in behavior, often impaired consciousness, maybe falls or movements, and that's caused by a brain abnormal electrical discharge. And we can even think of that as being like an arrhythmia in the brain. More complex, of course, than heart arrhythmias because of the complexity and the dynamic nature of brain networks. Oops, sorry, can I just... And so in the clinical setting, we characterize seizures in an electroclinical way. This is the basis of our classification systems. And so we can basically compare what the patient feels, what people can observe. We can record this on video, and that's what we call the semiology of the seizure. And then we correlate that with the brain activity measured on electroencephalography. So most of the time this is done using surface EEG with an array across the scalp, but in some cases we use intracerebral recordings, stereo-electroencephalography, becoming the most common method used in pre-surgical evaluation for selected patients. And stereo-EEG as a methodology is important for patient care, of course, and the main goal is to help to make these decisions on surgery for patients who need that. But it's been a very important methodology in shedding light on the network basis of epilepsy, on epileptogenic networks, as dynamic phenomena. And one of the most important and very early observations from stereo-EEG was that even when patients have a lesion in their brain, which of course may be the cause of the epilepsy, like a scar or a tumour or a focal cortical dysplasia or some other malformation, we know that across different etiologies, there can be quite a variable relation between the lesion and the seizure organization. So it's often not so straightforward as just finding a lesion on MRI. And from studying lots of series of patients over the years, this is a video from Marseille, one of the pioneering teams in developing SEG, We know from group-level studies that we can correlate clusters of symptoms and signs occurring during seizures. These are very complex patterns often, and there's a whole kind of spectrum of complexity. So some patterns are very easy for clinicians to recognize and then to predict which brain region is involved. Other ones are extremely complex, and that's the case for the patient I'll show you. And we can, at group level, map those quite nicely onto clusters of connected brain structures involved in the seizure organization. So there's a clear correlation of behavior to neural networks that can be demonstrated at the clinical level. And another important thing to keep in mind with EEG, although as clinicians we're kind of trying to find the zone of the brain that's causing the seizure production, and we want to try and treat that, ablate it or operate, in terms of the production of the behavioral disturbance, and probably also many of the other comorbidities of epilepsy, which include cognitive dysfunction or psychiatric effects, it's the temporal components of the network disturbance, as well as their spatial organization, which determine that clinical output. So that's another important kind of observation from EEG that we should also keep in mind in the case that I'm going to show you. We know as well that both seizure onset and the spread of the signal disturbance determine the clinical expression of the seizure. And all of this, of course, depends on the underlying connectivity of the system in which the seizure arises and then spreads. Okay, so I'm going to tell you about a case. So this was one of the early patients I saw when I first came to Brisbane just a few years ago. So this is an 18-year-old man. He's had epilepsy since his early life. Okay, he started having seizures very young. And he's got probably mild learning disability, very mild really, and does have some ADHD and some obsessive compulsive traits as well in the background. Now, he was worked up by a very, very good team in Melbourne as a young boy, and actually underwent surgery. So you can see on the scans there at the bottom, he's got this big missing piece of his right frontal lobe. So that was operated on. He actually had 2 frontal surgeries as a child for his epilepsy, and yet the seizures continued completely unchanged. So the surgery was ineffective, okay? The patient describes his seizures as a feeling. He can feel an onset, something in his heart and in his head, he would say. It's probably a feeling of his heart racing and possibly a feeling of fear. His mum certainly said his face looks frightened at the onset of the seizure. And then he goes into a very active, hyperkinetic pattern of seizures. This is a slowed down video. These are 2 different seizures. It was an extremely stereotyped sequence of complex repetitive movements involving the whole body. So in fact, the movements are faster than this. And when we met him, he was having up to 12 of these a day. He would have them in the clinic. He would fall off the chair. It was terrible. It was a very severe epilepsy. So we felt he was a candidate for further evaluation from a pre-surgical perspective. The standard imaging, so we did good quality 3 Tesla MRI with epilepsy protocol. He had standard PET scan. It really just showed these sequelae of the previous surgery. There were no convincing signs of abnormal cortical regions or grey-white matter differentiation. There was nothing very much else to go on. And the clinicians in the room will know that this type of hyperkinetic pattern is amongst the most complex clinically for us as clinicians to predict which brain regions might be involved. We can suspect the frontal lobes are involved, prefrontal cortex, but with the kind of autonomic symptomatology at onset, we were also thinking of a role for other brain regions of the limbic system, perhaps amygdala, perhaps temporal pole, perhaps insula. The lateralization was also very difficult from a clinical perspective, although there was much more evidence in favour of right hemisphere, as had been the previous side of operation. So we were lucky. We were able to actually send this patient down to Melbourne, to Swinburne University of Technology, and he underwent a series of additional multi-modal non-invasive imaging methods by Professor Chris Plummer, Dr. Simon Vogren and team. And you can see here he had electrical source imaging, magnetic source imaging, fMRI EEG. And this was made possible in a single session through a dedicated cap that's been developed by this team that is compatible with both MRI and MEG. And you can see these showed quite nice, fairly concordant interictal localization, interictal meaning in the resting state period, so between seizures. We didn't capture ictal data in this patient, indicating a likely role for mesial frontal cortex, anterior cingulate, perhaps mid-cingulate. And this was very helpful because this really, as clinicians, gives us something more to go on when we're planning an implantation strategy. So with stereo-EEG, we have a certain number of electrodes. In this case, we implanted 14 electrodes, most of them in the right hemisphere, but we also wanted to sample the left hemisphere because frontal seizures, especially involving anterior cingulate or mid-cingulate, are very often involving both sides of the brain. That's the same for insular seizures as well. So we didn't want to miss something that had perhaps become a bilateral epilepsy, even if at one point it had been more unilateral. You can see that we've sampled a number of structures. Each electrode is a kind of very thin wire with a number of recording points along it, usually 10 or 15 contacts. And these are implanted by a neurosurgeon under general anaesthetic, according to a predefined plan made in conjunction with the epilepsy team after usually months of workup. So we'd been doing this patient's non-invasive video EEG, of course he'd gone through all of the imaging and so on. And you can see we had quite nice sampling along the different parts of the cingulate gyrus. The goal is not to provide complete coverage. Of course, we can't cover the brain, but we can certainly sample what we know of connected structures and regions in order to be able to confirm or refute the main hypotheses of the epilepsy organisation. You can see we had to be quite creative with some of the trajectories because of the prior surgery. So we'd had this huge previous frontal resection, but we'd had an early resection in the right orbital frontal cortex because the Melbourne team, when he was a child, thought there was probably some abnormal looking grey-white matter blurring, perhaps a dysplasia. In fact, the histopathology was negative on that first resection. He then went back and had a second resection as a child, had right frontal operculum resected with ECOG, and that did show focal cortical dysplasia type 2A in the second resection, but didn't change his seizures at all. So it was a surgical failure. So you can see for this S' electrode, our surgeon placed it going into the left hemisphere, passing through the left anterior cingulate and into the right anterior cingulate. So we could sample both parts of the cingulate within the same electrode trajectory. So just to give you a sense of the sorts of data we're looking at, so SEG it's a complex methodology, and there's a lot of data to look at, and a lot of it is based on clinicians' pattern recognition. And so we're interested in looking at baseline resting state interictal data between seizures, and we want to look at spontaneous ictal data, spontaneous seizures, and we can also use stimulation studies, cortical stimulation, to see if we can trigger abnormalities resembling seizures. So this is just a snapshot of one of the pages. We've 100 or more channels of recording. And you can see the first impression we had was, oh gosh, well, he's got spikes everywhere. So widespread spiking, you can see across frontal cortex, temporal pole, even posterior cingulate, so even in parietal regions, to a greater or lesser degree synchronized or asynchronous. But when we look in more detail at certain regions, so here's a kind of zoomed in zone of the anterior mid-cingulate cortex on the right hemisphere, and you can see quite low voltage, quite low amplitude, and we think this is probably because the actual trajectory, when we look at the position, so after the SEG, we perform a CT scan, we can co-register that with the patient's MRI, so we have an exact position and even the coordinates of each contact. So this particular electrode was sitting very basally, probably at the junction of the gyrus and the underlying white matter. So I suspect that's why it's so low voltage. Nevertheless, in the actual abnormalities, we can see spikes and gamma band high-frequency oscillations. These are interictal biomarkers of epileptogenicity, especially when they co-occur. And this was maximal in the N electrode in the anterior mid-cingulate. And so we can often use quantified methods in SEG. This is becoming more and more useful and important as the methodology develops. And this is, for example, a snapshot of a 30-minute epoch taken during sleep. We can measure it during sleep and wake, and we can measure it across the week, so we can look for differences throughout the recording period. You can see here, if we just quantify the numbers of co-occurring spikes in HFO, the highest on this particular epoch were actually outside of the frontal lobe. It was temporal pole, posterior cingulate. But with Hamid Karimi Rose-Bahani from our lab, who's here, by studying the co-occurrence of activities between electrodes and looking at the temporal delay within a short time window, in fact, we can start to study the directionality of interictal spikes in HFO. And in fact, interestingly, and this was very stable across the whole recording period, across all epochs, we found that the N electrode, this one where we could see the visual HFO, seemed to be the outflow, the source of spiking, which could also be detected in other parts of the brain. And so we captured seizures in this patient as well. He had 9 seizures, looked overall very, very similar to all of the other stereotype seizures that we'd had in previous monitoring. And this is just a selection of some of the kind of relevant channels during the seizure. So you can see on the left, there's this kind of slow wave with low voltage fast activity superimposed on it. So this is a very typical kind of classical seizure onset pattern in stereo-EEG. And we sometimes call this slow wave shift. And this was maximal. I mean, we can see this visually as clinicians, that we can see the maximal slow wave shift and maximal fast activity occurred in the N electrode, followed by the electrodes on either side along the cingulate. So in fact, the maximal epileptogenicity in the seizure onset was not just posterior to the resection margin, it was actually quite a bit further back in the cingulate gyrus. And you can also see quite nicely in this page, we've got this propagation pattern. So when we talk about propagation in epilepsy, and particularly in the world of stereo-EEG, it's important to think about this as being a spatial and a temporal phenomenon. So we have a spread, so we're seeing spread from a initially, usually quite restricted zone, but of course sometimes some seizures start in quite a widespread region of the brain. We see spread to different structures or regions which are usually connected to the epileptogenic onset zone. But we also see, you can appreciate the morphology looks different. It's spiking, much higher amplitude, and the spikes become slower as we get towards the end of the page. So that's a propagation pattern, which we saw very reproducibly across all of his seizures, which was maximal in amygdala, temporal pole, insula, dorsolateral prefrontal cortex, and posterior cingulate. So this was quite a complex and fairly widespread epileptogenic network, albeit with a very reproducible and in fact fairly focal onset pattern that localized to the anterior mid-cingulate in our implantation. And the semiology tended to, again, reproducibly co-occur just at the end of the slow wave shift. So again, we can use methodology to quantify these signals. This is an illustration of an epileptogenicity map that's using Brainstorm. So this is open source software. And this is really mapping, it's really quantifying the amount of low voltage fast activity, the gamma band activity, and then tracking its spatial spread over time. Okay, so this particular time window is it starts 2 seconds before the seizure onset, and then tracks through what happens over the 10 seconds after. So you can see where it lights up red, and you can see on the screenshot on the right, the maximal is across this cingulate region on the right. Here it looks a bit more distributed than it looked on the visual analysis, but maximal in both anterior and mid-cingulate regions. And so we can also explore other ways of quantifying data. And for example, going back to the idea of what we did with the interictal spike in HFO activity, we can also think about directionality and measure that directly on the ECG signal. And again, this is work from Hamid, using a sort of simplified version of Granger causality to infer the flow of ictal activities, to look at directionality by looking at co-occurrence and delay between signal and different electrodes. And again, interestingly, despite the complexity of this boy's case and the complexity of his network, in fact, again, quite reproducible outflow from the N electrode. And we recently published work on this with Hamid, and if you're interested, he's got a poster in the session number 306. He'll be happy to talk you through some of his methodology. We used simulation studies in this boy's case. We could trigger seizure onset, not the full-blown seizure, but we got definitely some early motor. He recognized the seizure onset and he would start to move, and then he didn't progress into the full hyperkinetic phase, but we could trigger that from the cingulate region. Interestingly, we could also quite convincingly trigger the feeling of the seizure from the amygdala. So again, that's a bit of a red flag for me that I think he has got a widespread tendency to have seizures which, may well recur from other regions outside of the frontal lobe. So it's complex, but, the overall driver looks to be this anterior mid-cingulate region. So he was terribly disabled with his epilepsy, very keen to do something. So we had a lot of debate. We'd spoke to the Melbourne team who'd originally worked him up, got some input from Patrick Chauvel, who's an epilepsy expert as well. And we decided finally on a fairly limited resection. So we could have perhaps decided to go a bit larger, but we finally elected to do a fairly limited resection, which looks quite small compared to what was previously resected. Hyperkinetic seizures totally stopped. So he's not completely seizure-free though. He still gets, several times a month, he gets the feeling of the seizure starting. His mum cannot see anything. He says sometimes he feels like his hips are moving, but he can walk about, he doesn't lose consciousness, doesn't fall. So he's got a job, he's working, he's greatly improved. And we found FCD type 2A in the resected tissue, which is the same pathology as was on the second of the childhood resections that didn't help the seizures. So we can suspect that this boy probably has a quite widespread focal cortical dysplasia, a malformation of cortical development, which is, maximal, expressing maximally in this cingulate region. So that was a good outcome. And I think looking back, it was interesting to see how well that correlated with the pre-ECG multi-modal non-invasive imaging. So I'll finish there. Epilepsy is a complex condition, incompletely understood disorder of brain networks. Multimodal quantified data are very useful for starting to understand things better, and we can use the ECG, use the surgical outcome as a kind of ground truth to help us validate non-invasive methods. And we need really larger and kind of more homogeneous data sets if possible to assess applicability to other patients. And in the future, maybe we can bring in other modalities, start to quantify the behavioral disturbances of epilepsy, the seizures and the interictal abnormalities, and then add that in to the modelization of the data sets. So thank you very much for your attention.
Oh, sure.
Thank you very much, Aileen, for this wonderful talk. If you have a question, please come up to the mic in the middle, and we have time for one or two very quick questions, so don't be shy. All right, if not, but do you have one? I have one.
I also have one, but
okay.
Go ahead.
You talk about a lot about epileptogenic network. Is there a consensus on how many electrode is needed to map the full epileptogenic network? Is this case dependent? How do you decide on how many electrodes and what coverage you want to?
Yeah, that's a good question. There's definitely not a consensus. It's definitely an individualized case-by-case basis based on the patient, influenced by the team, influenced by the team's experience, influenced by the team's culture and, history. So most cases, the average used across the world would be around 15 electrodes nowadays. The numbers gradually increased over time as implantation methods become safer with better vascular imaging and so on. It's a very safe method, ECG. There's a very low complication risk. But I think it's a good point. There's definitely no real knowledge of standardization. I remember when I first went to Marseille, there were cases who only had 7 or 8 electrodes, well localized, operated seizure-free, with often quite hard to find focal cortical dysplasia, for example. So I think in the hands of an expert team, you do not need very many electrodes.
Thank you. Sami?
I'm just going to speak louder. I was wondering if you integrate CCEP in your workflow to try to understand the network. You mentioned Granger's causality, but I was wondering about CCEP.
Yeah, that's a good question. So cortical evoked potentials, lots of interest in using these. I don't personally. I know of lots of teams who've got very interesting work ongoing with those. It's a good way to study the long distance connectivity between structures, probably quite dependent on sampling in individual cases, what we actually see. But yeah, it's an interesting tool to add into the other tools that we have.
Thank you.
Time for one more question. Otherwise, I'll ask one. So for epilepsy standard of care, for like the drug-resistant cases, they often go to the monitoring unit, you taper off the medication, and then you let the patient seize. Do you think long term, there could also be a strategy to make this completely seizure independent, focusing only on interictal markers?
Yeah, that's a great question. There's lots of interest in that. And of course, some patients, we don't capture seizures when we want to. Sometimes we have to monitor, longer than we would like to in order to try and capture seizures. So there's lots of interest in using interictal data, which of course we can access much more easily with EEG, but also with MEG or with fMRI. And I think, as I mentioned, using ICG to validate what interictal measures can tell us would be a very important step for the future. And I think the early kind of studies using short extracts of interictal recording are very promising for predicting the ictal organisation, but again, quite depending on sampling. So I think what we need to move towards is integrating whole brain measures, fMRI, EEG, MEG, because that will give us that, additional kind of whole brain spatial coverage to analyse that.
Thank you very much.
Thank you.